TopMedTalk.
Well, hello and welcome to TopMedTalk. It's Desiree Chappell here, coming to you with one of our virtual recordings as a follow-up to one of the meetings we went to this past spring. Monty and I were able to attend the Society of Obstetric, Anesthesia, and Perinatology. We were able to catch up with some of the key opinion leaders, the presenters there, even some friends of the TopMedTalk family, and hear more about the area of obstetric anesthesia, which was fascinating, as Monty and I have not been to that meeting before. Well, at the time, we weren't able to talk to all the presenters, so we wanted to step back a moment and grab one of the presenters of a very special talk there at SOAP this year, which one of the delegates was able to sit with us on TopMedTalk and tell us more about. But it was all around the concept of trauma-informed care. So here to talk to us today, we have Tracey Vogel, who is an expert in this area. Tracey, thank you so much for joining us.
Thank you, Desiree, for having me join the show.
Yeah, absolutely. Well, for all of our listeners, Tracey, why don't you tell us a little bit more about yourself?
Well, I'm an obstetric anesthesiologist by training, and I've been doing that work for well over 20 years, but only in the last 12 years have I had the opportunity to work exclusively within obstetrics, which means I only work with pregnant postpartum patients. And it was really during that time, early part of this last 12 years, where I started to see things just a little bit differently. And being in that space, I was able to see trends. I had an opportunity to go and train as a sexual assault counselor, which really was my introduction to this concept of interpersonal trauma. And it was a real aha moment for me because I had to step back and say, wow, there's a lot of this most likely on our unit. And I have not had skills. I might not have been doing things correctly. It really was an educational experience for me. And then in the years that followed that, I started to work more closely with patients and decided to establish a clinic to fill this gap for patients. So I started a trauma-informed perinatal clinic, one of two in the country, and it serves individuals who have any history of trauma and who need help navigating childbirth. I also see patients who've had a traumatic birth experience who need help in processing. They want to know, what are the paths towards healing? I screen them and can get them into the hands of specific therapists and counselors. And I see people who've had traumatic births who don't know if they should get pregnant again. So it has been an absolute incredible journey to end up with this clinic. But the other thing I do is I train a lot about this concept of trauma awareness and trauma-informed practices to help deal with these patients or manage these patients, I guess.
Yeah. Oh, that's an incredible story. I know as we were preparing for our conversation today, you said you never imagined yourself getting into a space like this or a role like that at all.
No, in fact, a lot of people say, okay, you're an anesthesiologist. How is it that you are now doing psych work? And I say, I don't know. It's just a pathway and I just embrace it. And I think the more I learn, the better I get at some of these principles and practices. And I'm seeing how different the outcomes are for these individuals. And what I'm doing is trying to take what I learn and give that back to the communities, not just the anesthesia communities, but the obstetricians, the nursing staff, the NICU teams, the office staff want to know, hey, how can I do better with these patients? So, but I certainly didn't start out here. And that's why I have a lot of compassion and, have to allow a lot of grace for my colleagues who we say, are still inadvertently traumatizing individuals, but they don't know yet. They don't have the education yet. So hoping as time goes on, we can get that education to them.
What a gift to be able to give back to our specialty of anesthesia and specifically the obstetric world. And I know reach moms in such a way that is so non-traditional, but I'm sure so impactful. So that's really fantastic. We love to hear those stories here on TopMedTalk. Well, so I will, full disclosure, and I think we said this on the podcast that we did with Cheryl Parker at SOAP, talking about this concept. Neither Monty nor I had ever really heard of this in a formal way. And as we were talking about it and learning more about it, not being a person that practices in the obstetric world, but definitely does my fair share, and Monty along the years have done our fair share of traditional anesthesia in the field of surgery. We're called back to those days very recently where we have patients who have horrible anxiety, who they don't want their hands down, they don't want the face mask on. Thinking about it, it's like, wow, this could really be related to trauma that they've experienced in their past. And in fact, there are times in my practice that I've had patients tell me that before. So I think we're going to talk a little bit more about that later, because I'd love to talk about how this overlaps. But, is this something that everyone that's in non-obstetrics should be considering and thinking about at this moment?
Oh, absolutely. Trauma work needs to happen everywhere. Like, systems need to be trauma informed and working towards a healing centered, trauma responsive state. It's not just clinicians. And I work for an organization, volunteer for an organization in Pennsylvania called Heal PA, and a governor appointed task force with the hope of making the entire state trauma informed. So it's
not obstetric, just
everything. Just everything from education to law enforcement, child abuse centers. It's everything. But I chair the committee on the physical and behavioral health action team. So bringing trauma awareness and trauma informed practices into healthcare in general, of all levels and all types. So yes, everyone needs to understand it. It's because trauma is so pervasive. It's really everywhere. We think at least 60% of our population will have experienced at least one traumatic event in their lifetime, serious traumatic event. And so understanding how people react in stressful circumstances, especially those who have chronic, like unresolved traumatic stress, who've never had therapy, don't know how to respond to additional stress. That's what we see in the operating room. We see it in labor and delivery, in environments where control is taken from someone. And we think about, even in the general operating room, what you just mentioned, patients' arms are strapped, they're restrained. It's terrifying for people, depending on the type of trauma they've endured. But a lot of them, they see that as the epitome of loss of control. And that's why I think every medical provider, from the ER docs to urologists to OR staff, we need to understand trauma and what can we do to help these people. So yeah, it should be everybody, not just obstetrics.
Yeah, that's great. And I wanted to preface that conversation so that if people think, oh, this is an OB concept, it's really not. We all can learn about this. And as you said, I love that. I mean, every healthcare professional that is hands-on or in any type of way taking care of patients, we should know about this, because the numbers are staggering. I didn't realize it was as high as that is. And we can talk a little bit more about like sexual trauma and female trauma and things like that. But, we could assume that many of our patients are touched by this. So let's dig in a little bit more with the specialty in general and in the obstetric world. Obviously very sensitive, like I mean, being a mom myself, when you go through childbirth, just that all of it in itself could be kind of traumatic, even if everything goes perfectly. But talk to me a little bit about the specifics of, and if you can go into maybe some of the statistics about what we see as trauma, or what a patient actually sees as trauma, and what has been traumatic to them, and how many patients are we looking at here?
Well, we could divide that into, let's talk about those that come with trauma. Let's start with that. How many people already have trauma when they come? And to look at that, I think more of interpersonal traumas, because those are the type that impact patients uniquely, as opposed to natural disasters, for example, living through a hurricane or a tornado or something like that. So interpersonal traumas, they disproportionately impact women, first of all. They disproportionately impact women of color. Individuals who have mental and physical handicaps often have more of these interpersonal traumas, as do members of the LGBTQ community. So when you think of interpersonal traumas, I'm talking about things like sexual assault and trauma. So here's a statistic for you. So somewhere between 1/5 to 1/3 of all females will be the victims of childhood sexual trauma by the age of 18. And that is supported.
That's childhood trauma?
Yes, that's sexual trauma. And that is supported over and over again in the research. And we may be underestimating because so many people don't disclose. Okay, so think about that. If you extrapolate that number to how many are coming through childbirth or coming to the operating room for other procedures. So that's a very high number. I find it very profound. Like it's disturbing to me. Yeah. There are other statistics. For example, military sexual trauma. So those that are experiencing sexual abuses, assaults while in active duty, that is also about 25%. And the latest data that looks at lifelong exposure to sexual trauma in military female veterans is over 60%. So if you live in an environment where you have a high population of female veterans, they have a very high percentage or instance of experiencing interpersonal trauma. We know that about a fourth of all women will experience severe physical violence from a partner in their lifetime. We know that teenage moms, have a mean ACE score, which is Adverse Childhood Experience Score. I don't know if you've heard of ACEs, but this, and I can talk about that study in a second, but their mean score is about 5 out of 10 types of childhood maltreatment. A small study, but that's also being replicated. So when we have a teenager who's pregnant, we should maybe be thinking automatically that this person may have come from adversity or trauma. Here's another plug for let's use trauma, awareness for everybody or universal precautions. I'm a big advocate for that.
Just really quickly, I want to just make sure you just said to use it as universal precautions.
Yeah, it should be.
For every single patient.
Correct. And trauma-informed practices are very basic and full and respectful, holistic, and they don't cost a lot of money. They can be used universally with all of our patients. And we wouldn't miss anybody because the question is always coming up. How do we know who these people are? And how are we screening? That's the million-dollar question. Is there a universal screening method? And there are issues with screening for these kinds of sensitive topics and issues. And I really think if we just use universal precautions, we're not going to miss anybody.
Yeah.
So those are some statistics for you on interpersonal traumas. Now, I also want to mention, okay, that's what people may already come with to labor and delivery. But there are a variety of different intrapartum events that we know increase the risk for postpartum PTSD and postpartum mental health issues. And if you think about that, if we divide those into obstetric, anesthesia-related, and maybe fetal issues or neonatal. So number one, loss, we know is probably the most significant factor that increases the risk for postpartum mental health issues. But it also can be loss of a child to CYS, can increase the risk for suicide in the parent. So it's a different kind of loss. But even 1 hour in the NICU can create a very traumatic environment for parents.
CYS, what does CYS stand for?
Child and Youth Services. So if someone comes and has their baby taken from them because of perhaps substance use disorder, violence in the home, something like that, the impact on the parent is significant there as well. So that's, those are fetal issues. Of course, if the baby is sick for any reason, that can increase the risk for mental health issues in the parent. All right, then we have obstetric issues. We know things like severe physical morbidity, like having severe preeclampsia, for example, and having to go to the ICU can increase the risk. Severe postpartum hemorrhage, we also know increases the risk. But also what's interesting, they've done studies looking at our emergency responses. So what we think is the solution to physical morbidity might actually be creating psychological morbidity in a patient. Interesting, like we still need to continue to work on ways to not have 30 people rush into a room when a code obstetric is called, for example. So that can create issues. Now, from an anesthesia standpoint, we also have some studies showing that pain or inadequate anesthesia for cesarean delivery increases the risk. We know that difficult neuraxial placement, traumatic placement of the needle, nerve injury, untreated dural puncture headache, those can all increase the risk for postpartum mental health issues. But above and beyond all of those, the most notable risk factors for increasing that risk are things like feelings of powerlessness and loss of control, lack of support, and negative interactions with caregivers. Those are things we can change those. We have to do the research and all the other stuff too, but these are things we can do now. We can work.
Yeah, they are modifiable risk factors that all of us, listening to this today, anybody that hears about this concept can have a direct impact on, and almost immediately.
Yeah, exactly.
Boy, those numbers are staggering, and some of the things that you talked about. Tell me a little bit more about how this concept really has come about through all of this trauma and how it's weaving into the conversations that we're having in training and things like that. Because it was kind of a new terminology for me. I hadn't really heard about trauma-informed care before.
Well, I think it has some of its roots in the 70s. It started with learning more about war veterans coming back from the Vietnam War and having discussions with them. We also had the feminist movement of the 70s, and we started to hear the voices of survivors of sexual trauma and domestic violence now speaking out in rape crisis centers, which were popping up everywhere. We also had this, at that time, and even into the early 80s, there was more attention to childhood abuses, and more attention was paid towards that research and what are we doing about that in children's hospitals and those kinds of environments. As we moved into the 80s then, we started to get, in 1980, we had the diagnosis code, or we actually now had PTSD defined in the DSM. And so it didn't exist as a diagnosis prior to 1980. So that was a pretty monumental moment. And now people were looking at this concept of trauma, not just in war veterans, but now it was expanding. Childhood issues, learning about, like we said, domestic violence and sexual trauma and sexual assault. In the 1990s, somewhere in the 80s to 90s, we have the VA that's establishing the first center for traumatic stress. And then that eventually moves forward until we get to what we have now, which is SAMHSA, which is Substance Abuse Mental Health Services Administration under the federal government, Department of Health and Human Services. So those have all progressed as we've learned more and more about trauma itself, what it entails, how it impacts the brain, how it impacts the body. And then also we're starting to learn, how do we intervene? How do we work with individuals who have experienced trauma? So I would say it's been this progression since the 1980s, but it's only been in the last 7 to 10 years, I would say, Desiree, where childbirth, negative events surrounding childbirth have been included in the definition of trauma by the DSM-5.
That's so interesting. The more I've thought about this concept, we've been able to, like you said, now it has a label for that specific, patient population. But I think in society we're talking a lot more about trauma and traumatic events and how it impacts us and dealing with. I think the stigma around therapy has, changed. I don't think it's what it used to be. And I think we talk a lot more about that in society. Would you agree? Or
it's moving in the right direction, but I still think there's so much stigma, and there's still a lot of people that, even to talk about birth trauma, there's still a stigma with that. It's very hard for people to reach out, and that's why a lot of them suffer alone, because they don't feel they can talk about it. And I think that comes from our societal pressure on women and all birthing persons that is supposed to be joyful. This is what it is. And we put pressure on individuals to have birth a certain way. Otherwise, there's a triaging of sorts, right? This is the best. And then you have C-section, you're a failure. I hear this all the time in my clinic. That word failure, I have failed. I can't breastfeed. I've failed. And until we work with people to help them reframe how they see it, that maybe it's the fact that they were subjected to 48 hours of labor with no sleep, no food, and then they only get to labor on their backs. Perhaps their epidurals are too dense. They can't feel. They try, and then they end up with a C-section, and they feel it is their fault. They've done something wrong. And so it's hard for people to talk about. It still is, but it's still very difficult for individuals to verbalize other types of traumas as well. And that's why I think giving people the right space to talk about it is important, so that they can disclose and get the help they need.
Well, and I think in birth trauma, like you from personal experience, that I feel like it's like you think it's just part of the process. It's just like that was normal for that crazy thing to happen or whatever. You're having a baby, anything can happen. When it's not, it shouldn't, be like that. And it is hard for people to talk personally about their issues for sure. So let's talk about a little bit more about the work that you're doing outside of the OR, because it's fascinating, some of the things that you're working on, and the training would be great to hear about.
So this training came out of a concept that I had as I was developing my clinic. So I received a grant for a year to establish not only the infrastructure for this clinic, but to train as many providers as I could. Because the way I see it, I want to put myself out of business if I could in the clinic work. I would love for every provider to, again, right, to use universal precautions, to understand some of the nuances, to know how to work with individuals to get these really good outcomes. And so what I started doing was developing these training modules to help. And at the core, people need to understand the cognitive parts, right? What do you need to know? You need to understand, what is trauma? What are we talking about? How does trauma impact the brain? How does trauma live in the body of survivors that have had ongoing trauma prior to even seeing us in the operating room or in labor and delivery, for example? And then understanding, especially if I'm teaching in obstetrics, what does it look like when you have this intersection of trauma and obstetrics now? What does it look like? And then what's the impact, right? I have to get buy-in from people. I have to have people understand, if we don't prevent traumatic birth, here's the fallout. And it's so profound. And that's what people need to understand, like what happens. So part of the training includes didactics like that. It also includes communication strategies. What do we actually need to do?
Absolutely. How do you have a conversation about this?
Right? And it is a real shift from, and I can say to my anesthesia colleagues, well, when you sat with this patient for her C-section, did you give her the option of general anesthesia? Did you give her a choice? And they say, no.
No.
And I said, well,
why would I do that?
Right? That's part of this trauma work, is giving people voice and choice, telling them what their options are, because this could be someone who had significant pain or inadequate anesthesia with a prior C-section. She's coming in with no trust and a lot of anxiety. So she needs to know that you're hearing her. You're validating what happened to her. You're giving her options, but you can also then tell her about the risks and benefits of both, but in an unbiased way, but also tell her, like, what do you need to be safe in this environment? How could I offer you something different with regional anesthesia, for example? Like, make it better. Give her a sense of control to say, okay, I'll try it. But if I put the white flag up or tell you I'm done, I want that general anesthetic, that has to be honored and respected. So teaching people how to have these conversations and things that you can actually do is part of this training. I also do simulations, because I try to bring in as many different types of traumas in to help people work through and practice the skills that I teach them. But my favorite module in the teaching, and it's usually a full day in person, is all about perspective taking. And that's where we explore narratives that are written by patients. And I'm trying to get some from providers as well, because they experience trauma also. But to go through and talk about perspectives. What is this really like for the person on the table? We see them every day a certain way from our perspective, but what is it truly like for them? That is the most magical learning module of all, because I pair people up, different disciplines if possible, different levels of training, so that not only are you seeing a patient's perspective, but you're talking amongst your group with different people. So you're seeing their perspectives differently. And then we talk about it as a big group. And again, with all different types of traumas there as well, because I try to bring in as many with different learning parts in there. And then I use videos and we show different instances without and with trauma-informed practices to show contrast. So
interesting. I think from a clinician's perspective, we think that we know what the problem is or how to fix the problem. If someone is coming in and they're feeling very agitated or upset and we don't know what it is, but we'll just sedate it, whatever, fix it with a med or tell people to calm down, it's going to be okay kind of thing, when that's, I would imagine, probably not great and maybe even causing trauma in itself.
It depends. Every person, every individual is a little bit different. But I think as providers, when you recognize the signs of an acute stress response, like when somebody's angry or they come across as not being very nice, if we can learn to see these patients as symptomatic and not problematic, I think it helps us to say, okay, this is a trauma response, or they're really stressed. Maybe instead of me walking in there with my computer, I just pull up a chair next to them, be a human, and say, this can be a really stressful time. I get it. Is there anything that I can do for you right now in this moment just to help you catch your breath? And just give them a minute to calm down. It can be a very different start. And you sit down. Notice I said sit, because that's so important to get rid of that hierarchy, the physical hierarchy, with you standing above them. Even being in a gown can create a vulnerable space for these people. And you don't want to separate them from being able to get to the door. Never approach them from behind where you can startle them, especially if they're already agitated. There are little things that everyone can do, even in the 5 minutes an anesthesiologist might have before, a busy day in the OR, and that's all you have. My husband's an anesthesiologist too, and he's always telling me, Tracey, just remember they have 5 minutes. Teach them something they can do in 5 minutes. And I take that to heart because I get that. Like, you don't have much time, but man, if you pull up a chair and sit down and become a human with them and just let them tell you, or even an open-ended question like, what's on your mind today? What seems to be, the scariest thing about today? Because maybe we can make it better.
I've always felt like that's our job. We have about 5 minutes to ensure that the patient trusts us, or try and gain that patient's trust, but mostly that we are there for them and there to support them. So that's really impactful. I think that's what I really wanted to get at, lastly, is in that 5 minutes we have, you said a lot of different things, but if you could boil it down to like one or two, maybe three things that, us as team anesthesia, or any healthcare provider for that matter, but because we have 5 minutes and, either an obstetric or a non-obstetric case, what are top three things that we can really do? I know you said sit down and get at that level. Are there a couple other ones that, would work really well?
I think asking the individual what makes them feel safe is a very key question, open-ended question. What would make you feel safe in that operating room or afterwards? It could be a physical thing. They might tell you, I don't want my arm strapped down. I don't need that face mask on me. And then give them options based on what they tell you. So I think that's critical. And that's what I teach a lot with obstetric patients, especially. Also, asking them whether or not they've had bad experiences before, and if there's anything in particular that they could think of that would make this one better.
Wow.
And then listening. In those 5 minutes, I know there's so much we have to get at, but, listening. And then if you learn some more skills, looking at the cues, are they having that acute stress? Maybe even asking them about what helps them to calm down. They might have their own skills. They might use breathing. They might need music. They might use medication. Asking them, again, that's along the lines of safety, but what do you do to help calm yourself? And for the main operating room, I would also ask about, how do you wake up after they sleep?
Oh, yes. That is a very good question to ask. Some people who know that it's rather traumatic whenever they wake up, or they wake up swinging, they'll tell us, but not always.
Yeah. And they might not even associate the fact that their trauma might be at the core of why they wake up combative or hostile. We don't understand this completely. I think there's a lot more research happening right now in that space and wondering why. I know that using things like dexmedetomidine, maybe some propofol, some of these emerging might help as well, but also setting them up for a quiet space in the PACU. If you know that that's how they wake up, keep the operating room very quiet, right, on extubation, which I think is happening in most places now, but go that extra yard to make sure it's calm, it's quiet. They wake up peaceful. They have a peaceful recovery room spot. The nurses know, maybe don't startle them, let them wake up slowly and be prepared.
Yeah, absolutely. Those are all great ideas. Well, Tracey, as we close here, I know that you wrote an article back that was published in 2020 in Anesthesiology Clinics on trauma-informed care on labor and delivery. Are there other, and it's a great article, I was able to kind of read through it. Are there other resources or any other, well, first of all, this is a multi-layer question. What type of other research is going on in this space right now? What should we keep an eye out for? And then I want to end with some of the resources that are out there for us.
Well, we're talking about within the obstetric space with trauma and obstetrics. So we're seeing a lot more research coming out now in terms of, can we screen for trauma and what are the screening tools that we can use, both during pregnancy and then postpartum? And I've been privileged to be able to write some editorials for some of the upcoming papers that are actually looking at anesthesiologists' role in screening, which, may or may not be the most appropriate, given that we don't have that much time with patients. And to ask these very delicate questions might not be the perfect thing, but we still have a role in identification of a traumatic birth and reaching out to mental health specialists. But that's one area of research that's coming out. The work of Sharon Deacle out of Harvard, she's doing a lot of research, really setting the foundation for the fact that childbirth is a cause of PTSD, right? She's the one that started that. So she continues to do research establishing that. And I'm trying to think in terms of other things that are coming our way. I was just on the committee for obstetric anesthesia to the ASA. So we have just put our first round of a draft of psychological safety for the obstetric patient. So I say that, it's not ready yet, of course, but what it means to me is that the ASA is ready to look at this issue. And I hope not just for obstetric patients, but for all of our patients, because there are so many others that could benefit from trauma-informed practices too, like psychological safety for all of our patients. So that is something else that's coming. In terms of other resources, there are a couple of websites, especially for OB, which is patch.org and postpartum.net, which are really good websites and resources. I always throw my own website in there because if people want to reach out to me for training or they want to read the narratives, the testimonials that I put there.
They're great. So they're so impactful.
They are. And it's the patients enjoy sharing them too, because it's healing for them knowing that I'm using their narratives to help others through training. So that's out there as well.
And that's a resource really for, as you said, for patients, right? More on the patient-facing side.
And for us, I mean,
I was just going to say, but it's great for clinicians. I feel like I'm probably had more impact than a patient did from reading some of those things. Really, really gives you a perspective you don't necessarily always hear.
And then, of course, going to SAMHSA's site for understanding trauma-informed care practices. It's substance abuse, so SA, mental health, MH, services administration. That's a mouthful. That's why we always say SAMHSA. And they have a lot of really good resources there to get people started if they want to understand more about trauma and trauma-informed care.
Wonderful. Well, Tracey, this has been a fascinating conversation. We could go in so many more directions. I think we just scratched the surface on this one. But that's good. I am excited about future conversations. I am just so excited about this concept of psychological safety really infiltrating, our world of anesthesia and obstetrics. It's so important for our moms that we take care of and all our families and every patient that we take care of. So Thank you for the amazing work that you do and stepping beyond our normal world and really going out there and changing the world with what you do.
Oh, Desiree, thank you for saying that. That's very kind. And yeah, I just continue to do my part. And I appreciate you putting this out on your platform as well, because there are so many others out there that have a role to play. Look at all the things anesthesiologists are doing in this space already, which is, there are those that are exploring stellate ganglion blocks for PTSD, for example. Mm-hmm. There are those there's some at Stanford that are looking at emergence medications, anesthesia medications that are helping people process traumatic dreams. And then we have people that are creating templates for their intakes that include trauma questions, just everything in between and what they're studying. So I think everyone has a role to play. It's, I'm just kind of a messenger, trying to get it out there and sharing what I learned. So really, I'm very appreciative of being part of your show, and thank you for putting this out there.
Of course. Well, again, tell us your website again, how to find you there.
It's theempowermentequation.com, and I'm happy to share that with you afterwards, Desiree.
We'll put it in our show. Put all these things in our show notes. So if you have more information or would love Tracey to come and talk to your teams to learn more just about this concept and ensuring psychological safety for our patients, I'm sure she's happy for you to reach out, right, Tracey?
Absolutely.
All right. And thank you for listening to TopMedTalk. You can always find us on your favorite social media platform, X, formerly known as Twitter, LinkedIn, Facebook. We are there. We're going to be at some upcoming meetings, so check us out. We're going to be at the AANA, the ASA, EBPOM Dingle, which if you are in Ireland or ever wanted to go to Ireland, there's still time to book your ticket. It's an absolutely fantastic meeting. We are probably going to be at ISACHEM and the Perioperative Medicine Summit in Australia in November. So it's going to be a very busy conference season for us. Please check out all the content that we're going to be producing over the next several months. There'll be some good stuff in there, just like this conversation we had with Tracey today. So thanks so much for listening. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.